Thanks, Naz. Whichever appellation the calf strain goes by, whether it be tennis leg, the non-Achilles lower leg, or assessment of the triceps surae, it remains a relatively banal ultrasound examination. It's not a technically difficult study, nor are there any significant surgical implications. But despite this, it has been the source of so much confusion, so much frustration, and so much disillusionment throughout the course of my career that I once penned this worksheet. Now, this was the back end of a 12-hour shift, working with a radiologist who viewed ultrasound solely as a means to guide a HCLA injection, but this doesn't excuse that. But such was my confusion, such was my frustration, and such was my disillusionment that the hematoma between the medial gastroc and the Soleus, i.e. where the Plantaris is located, represented a Plantaris tear or rupture if you subscribed to such a theory. And if you didn't, but you called it as such, it represented yet another contribution to the most overcalled pathology in musculoskeletal ultrasound. Now, I had long ago accepted that ultrasound is not the most austere of disciplines, but this I found completely unacceptable. How could the diagnosis of such a common injury, such a crucial injury in the context of world sport, be so inscrutable and open to these arbitrary and ambiguous interpretations? From this low point in my career, I set about trying to answer that question and understand this entity, and what follows is the results of that process. I'll show you why this is not due to the Plantaris, and in doing so, attempt to account for a number of the confounding factors that tend to suggest otherwise. Now, the calf strain is a really common injury, so common an injury that you can make an entire team of footballers who at some point last season missed often significant game time due to a calf strain. So crucial an injury that it is arguably the reason behind what is generally considered the greatest achievement of the Australian test side in the past 20 years.
Oh, big shot, what's he doing? Gone!
Impact in line, wickets hitting.
Magnificent game of cricket here at Old Trafford.
Retaining the Ashes on English soil was due in part to Steve Smith
in the same test match for Stephen Smith
and Marnus, but more so because England's best bowler, Jimmy Anderson, bowled just 4 overs in the entire series due to a calf strain. The calf strain has decided state of origins. Influenced NRL premierships.
Souths are into week 2, the Roosters season is done.
And even impacted the preparation of the Wallabies at the most recent Rugby Union World Cup.
England triumph for Noita and advance to the semi-finals as they send the Wallabies home.
Given the aforementioned, it is truly staggering that the calf strain could pose such a diagnostic dilemma. But fact is, it has done ever since it was first described in the 1880s. And interestingly enough, one of the first patients to have a documented calf strain was Dr. W.G. Grace, the father of cricket, the world's very first sporting superstar, and a man who was once bowled and refused to walk. He said, "These people came here to watch me bat, not you bowl." W.G. Grace went to see Dr. Hood with, quote, "the characteristic sensation of having been smartly struck on the back of the lower leg the previous evening." The doctor was diagnosed with an isolated rupture of the Plantaris tendon, and even today you see imaging that's reported, articles that are published, threads that are tweeted that continue to implicate the Plantaris as the primary etiology of the calf strain. And it's reasonably easy to see why. Everyone here knows that the Plantaris is located between the medial gastroc and the Soleus, that it is a long, thin tendinous structure, and just like its homologue, the palmaris, it is vestigial. It's absent in a small percentage of the population and highly variable. So, when we cannot identify a Plantaris tendon separate from the hematoma that sits in its expected location, then it would seem a logical deduction and an appropriate application of reasonably sound MSK principles to presume or posit a Plantaris tear or rupture. But understanding why this cannot be the Plantaris essentially becomes an a priori argument. For how can such a small, and diminutive tendon, a tendon by definition is avascular, produce such a disproportionately large hematoma? And the answer is it can't, and it doesn't. To truly understand this entity, we need to turn to muscle architecture. Because if we understand how something is constructed, we understand the reasons how and why the muscle fails. The medial gastroc is a unipennate muscle. Its muscle fibres insert onto a peripheral tendon or aponeurosis. The distinction here is trivial, which is contiguous with the epimysium or the surface of the muscle. And this is why, when the medial gastroc tears, you have a hematoma that will accumulate along the medial gastroc, soleus and plantaris boundary, creating an image that can be a tremendous source of confusion, frustration and disillusionment to the uninitiated. So now that we've shown irrefutably that this is not due to the plantaris, the natural question that arises is, well, how do you describe it? Because to describe this as a simple musculotendinous junction tear is not in itself incorrect, but that does fail to encapsulate the wide spectrum and the complexity of these injuries. What does do that is the latest work coming out of Europe. Carles Pedret et al. Have proposed a model that looks at whether the medial gastroc tear involves the aponeurosis or not, whether that aponeuric defect is less than 50% of the transverse dimension, or whether it is greater than 50% of the transverse dimension, and whether or not there is involvement of the free gastroc aponeurosis. So a type 1 injury is a medial gastroc tear with no aponeurotic defect. So here you can see quite a small and subtle area of discontiguous muscle fibres consistent with a tear, that's denoted in red, and the aponeurosis is intact and normal, denoted by an unbroken white line. And I say the exact same on my worksheet, an X by Y millimetre tear of the left medial gastroc, discontiguous fibres with no aponeurotic defect. A type 2A injury is a medial gastroc tear with an aponeurotic defect that measures less than 50% of the transverse dimension. So here you can see quite a small aponeurotic defect, which measures much less than 50% of its transverse dimension. And this patient also had a concurrent soleal tear as well. A type 2B injury is a medial gastroc tear with an aponeurotic defect that measures greater than 50% of the transverse dimension. So these are often associated with the large hematomas that we see and are arguably the most common medial gastroc tear that we will encounter as sonographers. A type 3 injury is an injury to the free gastroc aponeurosis only. So this, in essence, is a proximal Achilles tendon tear and represents quite a severe injury on the medial gastroc spectrum. And this patient also had a DVT as well, which you see in probably around 50% of calf tears. This is a type 4 injury. So a type 4 injury is a mixed 2B and 3 injury. So you have a large aponeurotic defect and a concurrent tear of the free gastroc aponeurosis. This was a professional athlete 2 weeks post-injury. Both he and his team were at a loss to describe the slow process of recovery, and that is in essence because they underappreciated the severity of this injury. What they're also looking for here is whether there was a drainable hematoma to hopefully speed up that process. So I've been somewhat outspoken and critical of muscle injury classification systems in the past, but I do like this system. It's really easy to apply. There's a direct correlation with the type of injury and its severity. For example, a type 1 injury has a very short or small return to play time, whereas a type 4 injury has a delayed or extended return to play time. And unlike essentially all other muscle injury classification systems, this is an ultrasound-based model, which, if nothing else, is refreshing given a number of current trends within radiology. So all this, of course, is not to say that a plantaris tear does not happen. It can, it does, but it's rare. This is Tavita Pangai Jr. from the Bulldogs, who last year had what the papers actually reported as a Plantaris tear in this incident. Note where on his calf he reaches. If the Plantaris is to become pathologic or torn, it will occur at the mid to distal Achilles level. It will not occur at the level of the medial gastroc muscle belly, and it will almost always look something like this. If you see this appearance at the level of the medial gastroc muscle belly, this is not a partial thickness tear of the Plantaris. It's not focal tendinosis of the Plantaris. It's not a neuritis of a non-existent nerve, as I've once seen it described, but this is fibrosis or scarring of the medial gastroc aponeurosis. Now, this can be equally significant if you have a large enough amount of scar tissue that will disseminate the forces through that muscle tendon interface differently, leading to a decreased athletic performance and an increase in symptoms. Now, in a discussion of the calf, it would be remiss of me not to at least touch on the last member of the triceps surae, the soleus. Now, a number of studies have shown recently the soleus to be the most frequently injured component of the triceps surae, but doubtless this is a finding replicated in anyone's imaging department, and the reasons for that are a few-fold. These studies were performed on elite athletes, and the symptoms of a Soleus strain are rather indolent. So the average punter will not, or perhaps should not, seek imaging for what is general soreness or tightness. And lastly, the Soleus does not lend itself to easy assessment with ultrasound. But rest assured, if a patient does present with a medial gastroc or a calf strain, the medial gastroc is normal and the Plantaris is intact, the pathology will be within the soleus muscle, but this probably demands its own dedicated lecture. So if we put all of this together, I said at the start that this is not a technically difficult examination, but there are certainly technical considerations. If we come to scan a calf strain such as that occurred by Joey Mano in this instance, our inclination is to start in long with this image here. This is an aesthetically pleasing image, and we as sonographers are inherently aesthetes. But if we start in long, we are inviting error into our examination, particularly if there's a small hematoma, particularly if there's fibrosis or scarring of that medial gastroc aponeurosis. The key to scanning a calf, and this is true for most MSK examinations, is to start in transverse or short axis. In transverse or short axis, we can clearly see if there's an aponeurotic defect. We can see if there's any fibrosis or scarring of that aponeurosis, and we can see if the Plantaris is intact, or in this case, absent. There's a reason why radiologists look at more axial reconstructions than any other. I think I'll leave it about there.